My name is Eric Kazarian. I'm an otolaryngologist, head and neck surgeon, also known as an ear, nose, and throat doctor, and one of the relatively few surgeons in the world who specializes in the surgical treatment of snoring and obstructive sleep apnea. In this video, I will discuss surgical treatment of the tongue region. What I call the tongue region is the area lower down in the throat. The tongue region can play a major role in snoring and obstructive sleep apnea, and my research agrees with other work performed around the world, suggesting that about 2/3 of patients with sleep apnea have blockage of breathing in the tongue region. For a long time, it was not possible to treat blockage in this area with surgery. Fortunately, over the past 20 years, a number of procedures have been developed to treat this area of the throat. As I have said a number of times on these videos, the key in sleep surgery is identifying, then treating, all factors that contribute to sleep apnea or snoring in an individual patient. With the development of these procedures, studies show that combining them with palate surgery improves results. Blockage of breathing in the tongue region can be related to different structures, including the tongue itself, the sides of the throat, and the epiglottis. The epiglottis is a structure that functions like a trapdoor to cover the opening into your windpipe so that when you swallow, food and liquids do not go down the wrong way into your lungs. If you look at all tongue region procedures, they can have different outcomes, likely due to the fact that different people have different structures contributing to blockage of breathing and the fact that these procedures act on these structures differently. My research and the work of others examines how matching the right procedures to each patient can improve results. And I use this research in treating my own patients and when I give lectures to other surgeons throughout the country and around the world. Because I focus on surgery for snoring and sleep apnea, and have dedicated myself to being one of the leaders in the field, I perform more of these tongue region procedures than many other surgeons. However, in training other surgeons, I always stress that not only do you have to know how to do the procedures, but also you have to know when to perform them. Each of these procedures has pros and cons, and we will discuss some of the most common options. The tongue region procedures that are covered in this video are tongue radiofrequency, Genioglossus Advancement, Lingual Tonsillectomy, Midline Glossectomy, Upper Airway Stimulation, Hyoid Suspension, and Maxillomandibular Advancement. Tongue radiofrequency is a less invasive approach that treats the tongue itself. There are a couple of different technologies that can be used for tongue radiofrequency. They have some differences, but the basic way they work is by heating tongue tissue with a device that has a tip like a needle. The tip of the device is placed into the tongue where it is heated, creating a focused area of damage. The tongue is basically a large muscle, so the healing process converts some of this muscle to scar tissue, making the tongue slightly smaller. Because scar tissue does not relax during sleep like muscle does, tongue radiofrequency also makes the tongue less likely to fall back and block off breathing during sleep. Tongue radiofrequency is classically used to treat the back of the tongue, but I also treat underneath the tongue and the sides of the tongue based on the work of a Chinese surgeon who showed how to do this safely. Treating more of the tongue improves the benefits that you can achieve because you can get more of this tongue tightening effect. Tongue radiofrequency is less invasive and has a shorter recovery period than other tongue region procedures. It can even be done in the office, taking just a few days for patients to recover. One downside is that it does require 2 to 3 treatment sessions as opposed to the other tongue surgeries that are completed when performed once. Another tongue procedure is called Genioglossus Advancement. The genioglossus muscle is the major muscle of the tongue. It is anchored just inside the central part of the lower jaw in an area about as big as 2 fingertips. The procedure involves making an incision inside the lower lip, clearing the muscle off the front part of the lower jawbone, and then cutting a rectangular window in the jaw to capture the anchor point for the muscle. The teeth and the jawbone are left in place except for the piece of bone that is then pulled forward with the muscle attached and rotated so that it can be held in place with a small titanium screw. The procedure moves the anchor point for the tongue forward, making it harder for the tongue to fall back against the back of the throat to block breathing during sleep when our muscles are relaxed. We all know about the tonsils that we have on the sides of the throat. It turns out that we also have tonsils on the back of the tongue, called the lingual tonsils. With sleep apnea, there are a number of reasons that these lingual tonsils can become enlarged, and once they are enlarged, they often stay enlarged. Large lingual tonsils physically block breathing because they narrow the open space behind the tongue. For patients with markedly enlarged lingual tonsils, removal of them can be very helpful in opening up space for breathing. This procedure is done through the mouth with a curved instrument and telescope to see the back of the tongue as the lingual tonsils are removed. Studies show that many of the procedures we have for sleep apnea do not work as well in heavier patients. One reason why may be that as we gain weight, fat is deposited not just in our belly area and hips. There also may be fat deposited in the back of our tongue and around our throat. What this does is make the tongue and tissues on the sides of the throat larger and therefore more likely to block breathing during deep sleep when the muscles in our body relax. Weight loss is helpful for reversing this, but some patients require procedures that reduce the tongue size by removing part of the back of the tongue. There are a number of techniques that are grouped under the term midline glossectomy, or removal of part of the tongue tissue. The idea of reducing tongue size for sleep apnea has been around for a while, but when these were first done, it was performed with laser or regular cautery. This was very rough on patients, and surgeons basically stopped performing them. Fortunately, there are some new technologies and procedures that allow us to do this with less risk and a much easier recovery. Upper airway stimulation is a technology used to treat sleep apnea. It basically functions like a pacemaker for the tongue. As we have discussed, during sleep, the muscles in our body relax, and the tongue, which is mainly composed of muscle, can fall back to block breathing and contribute to sleep apnea. Upper airway stimulation works by counteracting this muscle relaxation in the tongue. The upper airway stimulation system is placed inside the body during a surgical procedure. There are three parts to the system: the pulse generator, stimulation lead, and sensing lead. Similar to a pacemaker, an implantable pulse generator sends an electrical signal through the stimulation lead to the major nerve that controls tongue movement, a nerve called the hypoglossal nerve. The sensing lead measures breathing patterns so that the system knows to send this signal specifically when you are breathing so that the tongue moves forward and opens the space for breathing in your throat when you need it most. Upper airway stimulation has an easier recovery period than some other procedures, but it is different in that there is a device placed inside the body. This is done during a surgical procedure, and after a month to allow for healing, the system is turned on and then adjusted to provide the settings that will offer the greatest benefit without waking you up. Of course, you'd only want this system turned on when you sleep, and all patients have a remote control to turn on the system at night when they sleep and pause it if they wake up. The hyoid bone is a horseshoe-shaped bone in our necks, sitting right above the Adam's apple. The hyoid bone is relatively thin, but it has attachments to other structures, such as the epiglottis, as well as some muscles of the tongue and the sides of the throat, or lateral pharyngeal walls. The hyoid bone is unique in humans in that it is not firmly anchored to other bones and therefore has some freedom to move around. During deep sleep, when muscles relax, the hyoid bone can fall back somewhat, allowing everything attached to it to do the same. The idea behind this procedure is that pulling the hyoid bone forward and anchoring it also pulls forward and anchors everything attached to it, stabilizing the airway in a different way. There are a couple of techniques, but the way I do the procedure is to pull the hyoid bone forward and anchor it to the top part of the Adam's apple cartilage. This enlarges the tongue region in a different way than the other tongue region procedures. My research has shown that it may be especially helpful for those patients who have the epiglottis playing a major role in their sleep apnea, and I perform it only when an evaluation makes it seem like it would be particularly helpful. Maxillomandibular advancement, or bimaxillary advancement, moves the upper and lower jaws forward. This enlarges the entire length of the throat, treating both the palate and tongue regions. Moving the jaws forward brings forward everything attached to them, such as the soft palate and tongue. This creates more space for breathing by making it harder for these structures to fall back all the way against the back of the throat. Studies have shown that maxillomandibular advancement generally has more consistent results than other procedures, but the limitations include the fact that it is a much bigger surgery and has a longer recovery period than other options. In some cases, it can be a first-line procedure, but it is generally reserved for patients in whom other procedures have not achieved the results we want. We are fortunate to have a combined team approach, in that I perform this procedure in combination with colleagues from oral and maxillofacial surgery. I believe the combination of our teams provides greater safety and improved results for our patients. Oral appliances are specialized devices that patients wear in their mouth while they sleep to help with snoring or obstructive sleep apnea. They fall into two categories: mandibular repositioning appliances that move the lower jaw forward, and tongue retaining devices that hold the tongue in place, basically with a suction cup, and prevent it from falling back. Most patients find the tongue retaining devices uncomfortable. Of the mandibular repositioning appliances, there are about 80 to 100 available on the market, and there is little evidence to say that one works better than another. Each of these appliances is similar to a double retainer, with one part on the upper teeth and one part on the lower teeth. They are combined together to hold the lower jaw forward, trying to open up the area behind the tongue. They come in three varieties. The first is the boil and bite type, similar to athletic mouthpieces that are placed into hot water and then placed inside the mouth so that the soft plastic portion can mold around the teeth. These are generally cheaper than the others, but they can also be more bulky and less comfortable. The other two types are custom made by dentists, and I work with dentists that have a specific focus in sleep dentistry. They are a little more expensive, but for some patients with obstructive sleep apnea, they can be at least partially covered by insurance. The two types of custom-made devices hold the lower jaw forward either a set amount or have a mechanism inside so that they are adjustable and can bring your jaw forward gradually over time. Oral appliances have some downsides, including the fact that, like positive airway pressure, for them to work, you have to wear them and sleep comfortably with them in place during the night. The risks include the fact that holding your lower jaw forward can lead to issues with the jaw joint, or TMJ, tooth movements that can change how your teeth fit together, or tooth pain. These are not life-threatening problems, but they can be problems nonetheless. A key part of my evaluation is getting a sense of whether a specific patient might really benefit from these before we think about trying them, especially if someone has to pay out of pocket for them. I hope you have enjoyed these videos. I'm committed to educating patients and colleagues, as well as advancing the field of sleep surgery through research. This has allowed us to be a leading center, offering world-class treatment for patients with snoring or obstructive sleep apnea. I update my website regularly with information about new technologies or studies, so please do check the website for the latest developments.